and welcome to People Making a Difference. My guest today is Dr. Clyde Yancy. He is the Medical Director at the Baylor Heart and Vascular Institute and Chief of the Cardiothoracic Transplantation Unit at Baylor University Medical Center in Dallas, Texas. He has been the recipient of numerous honors and awards, the Marquis Who's Who in America, the Cardiologist in Training Hero Award from the Association of Black Cardiologists, Outstanding Teacher at the University of Texas Southwestern Medical Center, and has been listed as one of America's top physicians in D and Texas Monthly magazines. He was named Physician of the Year by the American Heart Association, and currently he is the President-elect of the American Heart Association National Office. He joins us today to discuss heart disease. Thank you for coming.
I'm happy to be here, Robin. Thank you very much.
Let me first ask you, why did you select cardiology, specifically heart transplantation, as your area of specialty?
My passion, and I do mean to use the word passion, for cardiovascular diseases has been with me since I was a college student. I remember finding cardiovascular physiology as a freshman college student at Southern University in Baton Rouge, the most phenomenally interesting thing I'd ever seen, and I was totally enthralled with the way that heart cells interface, interdigitate, and are able to move and do so effortlessly and almost without fatigue. That just really captured my attention. I'd already committed myself to pre-med, and I knew then that something within the cardiovascular sphere would really reflect what it was that I wanted to do. And that was only reinforced as I completed my college training, went on to medical school, was exposed to the various disciplines, thought of others in fact, and then came back to the fold. And it has, for me, been a right place, right time, good fit, and I'm just humbled and blessed to be able to do the things that we enjoy and to try to make a difference. And heart disease, because of the compelling burden it has in our society, is an area where we need so much concentrated effort. It continues to be the leading cause of death and disability in this country, and even though we've made great inroads, we still have a long ways to go. Now, with regards to heart transplantation, like most things in life, it really turned out by serendipity that I ended up there. Of the different spheres that are within cardiology or cardiovascular disease, the place where I kind of landed was in looking at chronic disease, advanced disease, something that typically is called heart failure. And especially when I experienced my coming of age as a professional, it was transplantation that represented the penultimate treatment for patients with disease that was refractory to other medical interventions. We have a different slant on transplantation now, but it still is a very viable part of the management scheme for advanced heart disease. But it also sensitizes me to a message that has become even more relevant to me at this point in my career, and that's that the best way to treat heart disease is to never get it. So the prevention theme resonates with me now more clearly than ever before, but it's from the context of having seen advanced disease. So I grew up wanting to do cardiovascular medicine, cardiovascular science, and I continue to make my best effort to make that happen. And again, it's just a privilege and a blessing to be able to do this.
Was there something in your early childhood, a parent or grandparent? I know that I had a grandmother who died of heart failure. Was there someone in your life that struck you in that way that made you decide to go in that direction?
You know, in a more generic sense, it really was my mother as a science teacher, as my science teacher, that made it evident that science would be deeply embedded in something that I did or else. But fortunately, all of the dimensions in life lined up correctly. And so I loved my mother. She's passed on now with heart disease. I've enjoyed my discipline and just trying to make a difference and give something back.
So she was able to see you become a doctor.
Even beyond that, she was able to not only see me become a doctor, but periodically would prompt me through her readings and say, now, are you aware of this? I saw this on the news. Thankfully, and I mean this with all appropriateness, this was before the internet. Had she had access to the internet, I'm certain it would have been a very different experience.
Wow. there are groups of people that are lacking the availability of heart transplants, meaning hearts are not available for all ethnic groups. Are there particular groups that need to be aware of this, and what can these groups do?
So Robin, let's start this discussion thusly. Let's talk about heart transplantation generically. What is it? Why do we do it? Heart transplant really is the process of taking a donor heart, unfortunately from someone who's had a precipitous death, brain dead, but the heart is still viable, matching that heart based on blood type, what we call ABO typing, and body size, and then transplanting that heart into an individual with far advanced chronic disease or a serious acute disease, that is something abruptly has happened and caused cardiovascular collapse. We go through a thought process of what constitutes a need for heart transplantation, and then we go through a different process of who's a good candidate. They are not exactly compatible themes. We have to be certain on the one hand that someone has exhausted all the other therapeutic options and is indeed so sick that without doing the transplantation, their life expectancy would be measured in weeks to months. On the other hand, the rest of the organ system functionality, be it kidneys, lung, liver, etc., has to be appropriate so that they can survive the operation and the aftercare. And then there are all the other things in the psychosocial bucket that have to do with access to care, insurance, family support, lifestyle, behaviors, etc. So it's an involved decision, not made by one person, but by a team of practitioners, a team of concerned parties that look at all of the potential candidacy issues and then reconcile that this person is a candidate. With regards to outcomes, in the beginning, any of us that are anywhere near the 5th and 6th decade of life or beyond, that is 40s and beyond, understand that there was a time period back in the early 70s where literally there was a moratorium declared on heart transplantation because the results were uniformly bad. Patients did not survive for a long period of time. And it became evident that it required more than just good surgical skill. There was a certain biology of being able to tolerate a transplanted organ that had to be overcome if we were to expect long-term success. That occurred somewhere in the late 70s, early 80s with the discovery of very novel drugs that were able to prevent the body from rejecting the transplanted heart. And so from about the mid-80s forward, we've experienced a meteoric improvement in expectations. We haven't exactly experienced a meteoric rise in the number of heart transplants because we're limited by the number of available donors. So let me give you some numbers. There are about 100,000 people per year in this country that are sick enough that theoretically a heart transplant might be of benefit. Of that group, about half or more, for a variety of different reasons, just aren't good candidates. And that within the group that remains, a number of them have issues related to access to care, insurance, lifestyle, that further disqualifies them. So there's a cohort of maybe 10 to 15,000 people per year in whom this might be reasonable therapy, but there are only 2,000 hearts per year available for transplantation. And we dispense those hearts according to acuity, that means according to need. So someone with the most compelling heart circumstance is more likely to get the heart than someone who's waiting at home comfortably. It's not meant to make anybody at home suffer. It's meant to apportion the hearts to those that have the greatest need and the most immediate need. And so we have a circumstance in our country now where there's a finite number of people that receive a heart transplantation for treatment of their advanced disease. Now, one of the nuances in that issue of availability of hearts and then providing hearts to people with need is that the profile of those